Chapter 10, Alterations in Immune Function. So in this chapter, we're going to talk about the immune system. We'll discuss innate and adaptive immunity, cell-mediated and humoral immunity, and then we'll also discuss passive and active immunity. Then we're going to move on to some common immune disorders like autoimmunity, hypersensitivity, and deficient immune function. So let's review the immune system. So what's the purpose of the immune system? Well, number one, it defends our body against foreign invaders. So bacteria, viruses that can infect us, our immune system will try to eliminate. Number two, it also removes our own cells that have died or been damaged. And then number three, it attempts to recognize and remove abnormal cells. So mutated cells like cancer cells, which we discussed last week. Now, the immune system to work well has to have specificity and memory. So that will enable our immune system to distinguish self from non-self cells. So we are going to try to make sure that our immune system only targets cells that it should attack and keeps our normal cells alone. Okay, so if our immune system is very good at doing that, then we say we have immunocompetence. If it's not very good at doing that, then we are immunocompromised. Now, there are three lines of defense for us to protect ourselves. So number one, we have a physical and chemical barrier to infection. So here we're obviously talking about the invaders. So our physical barrier, an example would be our skin. We also have our mucus that lines, for example, our respiratory tract and GI tract. And then we also have chemical barriers, like think of the acids in our stomach. Then we also have the inflammatory response and the immune response. So this is once the infection has reached inside our cells, how we will respond to those issues. And for the immune system, again, we will discuss both innate and adaptive immunity. So in innate immunity, this is innate, so it is always present. It doesn't require a previous exposure to the antigen to work, and it's non-specific. So it doesn't distinguish between different microbes. If it sees something as foreign, it will respond. So the response is very quick, so it's an immediate response, and it involves your natural killer cells and your phagocytic cells like your neutrophils and your macrophages. Inflammation is an important aspect of innate immunity. So we see inflammatory response. So we'll see things like increased vascular permeability and vasodilation. So why do we want that? We want to vasodilate to bring more blood to the site of infection, since our white blood cells are carried in blood. We want to increase the permeability of our vasculature so that the white blood cells that are brought to the area are able to escape out of the circulatory system and get into the site of infection. So that will happen. So we have the emigration of leukocytes like neutrophils and macrophages out of the blood into the area of infection. And then they'll do their job. So these are phagocytic cells, so they'll phagocytose, and we'll see signs of inflammation. So those signs include redness in the area, swelling, heat, pain, and loss of function. So what's the purpose of inflammation? It's to neutralize and destroy invading agents, limit the spread of the infection, and then also prepare the damaged tissue for repair. So it's a good thing. It's just not good when it happens when it shouldn't. All right, so let's now discuss adaptive immunity. In adaptive immunity, we are going to attack specific antigens, so specific bacteria and toxins that have invaded our body. The response is a lot slower, but it's a lot more effective, okay? Especially after that second exposure. It's going to involve both your T and your B lymphocytes, or your T cells and your B cells. And the mechanisms include cell-mediated immunity and humoral immunity, depending on whether we're talking about our B cells or our T cells. Now, these lymphocytes, where do they come from? Well, all white blood cells come from our bone marrow. Most of our blood cells come from our bone marrow, mature in our bone marrow, and that includes our B cells. But the T cells will be born in the bone marrow, but it will actually migrate to the thymus gland and mature there. So cell-mediated immunity. This is where we're talking about our T cells, our T lymphocytes. So it's going to involve our phagocytic cells that attack specific antigens, and we have our cytotoxic T cells, helper T cells, and suppressor T cells. So cytotoxic T cells has the word toxic in it, so it's going to have some sort of impact on the cell that destroys it. So what these cells do is they bind to the surface of infected cells and they disrupt the membrane and it destroys that infected cell. So if you look over here, we have a virus infected cell. Now, every normal nucleated cell in your body, so we can talk about a hepatocyte or a muscle cell. So every normal cell in your body that has a nucleus, on the surface of their membrane, they have a receptor called MHC1. MHC stands for Major Histocompatibility Complex. When this normal cell in your body gets infected, in this case it got infected by a virus, this cell will present a piece of the virus onto its MHC1. And when it presents it on the MHC1, it is essentially letting the white blood cells know that it got infected. Because if the infection goes into the cell and stays inside the cell, other cells outside of it have no idea that it's infected. And so what you're going to do instead is present a little piece of the infection on the cell surface. So now your cytotoxic T cells can come and bind and recognize that you were infected. And so what is it going to do to you who was infected? It's going to destroy you. And that's why it's your cytotoxic T cells that are going to bind and respond. Now, if we're going to look at our immune cells like a macrophage, the job of a macrophage is to be phagocytic. So it will actually phagocytose a virus if it sees it. And so when you phagocytose that virus, typically if there's one, there's probably more. And so this macrophage is going to take a piece of that virus again and present it on its MHC. On the immune cells that have MHCs, they have MHC2. And when it presents it on its MHC2, the helper T cells will bind and recognize, hey, macrophage, you have a virus piece on you. That means you found a virus and you phagocytosed it. That must mean there might be more around. So what is the helper T cell going to do? It's going to call for more help by activating other cells like B cells. So that's the difference between cytotoxic T cells and helper T cells. We also have suppressor T cells, which reduces the humoral response. And the humoral response is what we will talk about next. Those involve your B lymphocytes. So your B lymphocytes, when they get activated, can turn into two types of cells, either your plasma cells or your memory cells. Your plasma cells do a very important thing. They make your antibodies. And antibodies are important because they help you destroy bacteria and viruses and basically make sure that your body is not being invaded. Your B cells can also turn into memory cells, and memory cells do exactly what the name says. It sticks around and helps you remember the infection so that if you get infected again, you can initiate a much more robust response. And it's able to do so, the memory cells are able to fight future infections without needing the help of a helper T cell. Okay, so let's take a look at a primary immune response. So the first time, let's say, some virus infected your body. So in this primary immune response, we're going to see macrophages phagocytose or eat that antigen, that virus. And so the macrophage will take a piece of it and it will present it on its MHC2. And so if you recall, it's the helper T cell. So TH is your helper T cell that will come and bind. And what is the helper T cell do? It calls for more help. And one of the ways it calls for help is by activating your B cells. When you activate your B cells, they become plasma cells. And remember, plasma cells make antibodies. And so what you're seeing over here is you have your initial infection of your antigen. And so that pathogen is in your body kind of floating around. Eventually a macrophage finds it, and then the helper T cells get activated. Then the helper T cells activate the B cells, which turn into plasma cells, and then they make antibodies. So it takes a little bit of time. And so if we are to measure or keep track of antibody levels, notice it takes about 2 weeks for your antibody levels to peak. That means that infection had about 2 weeks to kind of do its thing in the body, and so you're likely to have probably gotten sick this first exposure. Okay, So this is why you get a vaccination. When you get a vaccination, what you're trying to do is you're trying to turn on this primary immune response and make some antibodies, yes, but more importantly, you are trying to activate your B cells to make memory cells. Because remember, B cells can turn into both plasma cells and memory cells. And these memory cells can stick around and remember, and they don't have to wait for helper T cells. They can just stimulate and make antibodies. So now when you're exposed a second time to the same antigen, notice because we have these memory cells that remember, they can stimulate plasma cells to make antibodies much more quickly. So notice within days, and not only quicker, you also make much more antibodies. And so you're going to saturate your body with antibodies. And if these antibodies bind up all of the pathogens and form an immune complex, those pathogens really can't do damage to your body. So a booster shot is really designed to activate the secondary immune response. So it's supposed to boost your body, activate the memory cells, and increase the antibodies in your body before, let's say, you're going to a region where you know some infection is likely to come into your body. Okay. One thing you are seeing here are the types of antibodies that are made in your primary and your secondary immune response. So here's your primary immune response. They've kind of differentiated the antibodies, and here's your secondary. And the point is you really make your IgMs first, but you make more IgGs. So most of your antibodies are IgGs, although the IgMs are the ones you make initially. So speaking of the IgGs and IgMs, that stands for immunoglobulin. So that's just another word for antibody. And there are 5 classes of antibodies. We have IgG, IgA, IgM, IgE, IgD. Notice it spells the word gamed, G-A-M-E-D. So something about each of them. So IgGs, they make up about 80% of your circulating antibodies. So most of your antibodies are IgGs. And it's the major antibacterial and antiviral antibody. These are also the smallest, which allows it to cross the placenta, and it gives the newborn baby the mother's immunity during the first couple months of life. IgA is found in things that are secreted, like saliva, sweat, tears, mucus, bile. So it really protects from things like respiratory infections and GI infections. IgM, remember when we made our antibodies in our primary and our secondary immune response? Those were the first antibodies produced. They are also found on the surface of your B cells. IgE, think of allergy. So it initiates the inflammatory response and allergic reaction. So when you think of allergy, think of IgE. And then the IgD is also found on the surface of your B cells, again, along with the IgMs. So let's discuss the difference between active and passive immunity. So when we talk about active immunity, we're talking about our immune system actually being activated and working. When we talk about passive immunity, our immune system is not being stimulated. Instead, something else is being injected into our body and doing the work. So our immune system is being passive. So here we have a woman who was bitten by a rattlesnake last summer, and she received anti-serum against the snake venom, and she survived. So here we're really going to imagine that as soon as she was bit, she got that injection. So the injection is what did the work. This summer, she's going to be vacationing in the same area, and she wants to know whether she should get a booster shot against the snake bite before her vacation. So here what really happened was she has passive immunity. The anti-serum that was injected into her did the work to deal with the snake venom. Her immune system was never activated. Now remember, a booster shot is designed to activate your secondary immune response. Because you never activated a primary, she can't activate a secondary. So the anti-serum gave her passive immunity. It only lasted as long as the anti-serum remained in her blood. A year later, it's going to be gone. So she never developed any antibodies against the snake venom, so a booster shot really will have no effect. Now here we have a woman's baby, and here the baby is going to be a 1-month-old baby. So it's a newborn baby who is tested as being HIV positive. Does this mean the baby has HIV? Well, the answer is no. Why? Because the baby received passive immunity from the mother. Remember, the mom's IgGs cross the placenta. And so this baby might be infected with HIV, but the baby may not be. The antibodies that we're seeing against HIV might have come from the mother. So we really know nothing about the baby status if we test a newborn baby. Does it mean the father has HIV? No, because the baby gets its antibodies from the mother, not the father. Does it mean the mother has HIV? Yes. That's the only thing we can confirm for sure, that she is HIV positive to have passed the antibodies to the baby. All right. The woman says, this woman with HIV says, hey, well, if my immunity went to the baby, to my child, then my baby doesn't need any vaccinations. Is this correct? The answer is no. The baby did receive antibodies from the mother, but remember, that's passive immunity. Those antibodies will eventually disappear from the baby. So a vaccination will cause the baby to develop active immunity and make its own memory cells. Now, what about how the elderly? How does the immune system impact the elderly? Well, as you age, unfortunately, we see a decline in the ability to adapt to environmental stresses. And one factor that might contribute to that is a decline in immune responsiveness. So as you become older, we become more susceptible to things like infections and immune disorders and incidence of cancer. Remember, one of the functions of the immune system is to recognize and destroy mutated cells, right? Abnormal cells. Also, as you age, vaccinations become less successful. Now, the mechanism isn't really fully understood, but it is something that we see happening as people age. It's just a part of aging. So here I have a flow chart that lists all of the things that could happen in an immune response, and I'd like you to put this into this flow chart. So we're going to do this together, but hopefully you will pause this and attempt it on your own. But here we have a macrophage that ingests an antigen. Once the macrophage ingests the antigen, it will digest that antigen. So it ingested, let's say, the virus. So it's going to destroy that virus and break it up into little pieces. And then it needs to let others know it was it phagocytosed a pathogen. So it will take pieces of it, epitopes of it, and attach it to the MHC2. And when you attach to MHC2, the helper T cells will come. But just so that we can talk about both T cells, here we have the macrophage will present it to T cells. And the T cells can divide, and we have two types of T cells, the helper T cells and cytotoxic T cells. These are our main guys. So the helper T cells, what do? They call for more help. And one of the ways it calls for help is by activating our B cells. So when we stimulate our B cells will divide into our plasma cells and our memory cells. Our memory cells will stick around and remember to see if the same pathogen infects us. Plasma cells do a very important thing. They make antibodies. And those antibodies hopefully will go out and attach to the antigen, forming an immune complex. And once it forms an immune complex, it will help phagocytic cells find the antigen so we can get rid of it. We might activate the complement and cause little water pores to be inserted into the pathogen and cause it to lyse and get destroyed. Now going back, cytotoxic T cells, it has the word toxic in it. So what does it do? It destroys cells that have been infected. So it destroys cells whose MHC1 shows that it has been infected. All right, so now let's move on to some common immune disorders. So alterations of the immune function are typically either having an excessive immune response or a deficient immune response. So in an excessive, or two examples of excessive immune responses include autoimmunity and hypersensitivity. So in autoimmunity, the immune system attaches to our own tissues, causing an abnormally excessive immune response toward that tissue, and essentially we start to destroy our own tissues. In hypersensitivity, we have an overfunctioning of the immune system. So this is an example of an allergic reaction, so a response to an allergen. And then we have our deficient immune response. So this is where our immune system is depressed, it doesn't work as well, or it's completely absent. So let's talk about each of these, starting with autoimmunity. So autoimmunity again occurs when the immune system recognizes one of our own cells as foreign and mounts an immune response against our own cells, causing injury to our own tissues. So why does this happen? Well, there are some theories. The first one listed is your antigenic mimicry theory. And here's what this says. This says, hey, look, our own cells and even foreign antigens, they're pretty much made up of the same building blocks, the same materials. So when there's a small alteration in one of our own normal cells, it all of a sudden might look foreign, and so our immune system initiates an attack. Then we have release of sequestered self-antigens. So some antigens, or antigens are basically anything an antibody binds to, are sequestered during development. So during fetal development, our immune system goes around and it recognizes our own cells and it knows that it's our own cells, so we're not going to mount a response. But some antigens are sequestered during that time, and so our immune system never meets it. And it's supposed to stay sequestered. But if any of these antigens kind of escape, then our antibodies will mount a response because it's never learned that this is part of our body. Then we have our T cell theory, B cell theory, mast cell theory. This really goes into issues with all of these types of immune cells. So T cell, maybe the thymus gland is defective, and so we have decreased suppressor T cell function or altered helper T cell function. In B cell theory, we have issues with our B cells. In our mast cell theory, we have issues with our mast cells. So these are all theories of why autoimmunity may occur. So what triggers autoimmune response? Well, gender does play a role. Females have a higher risk than males. If you are getting sick all the time with infections, so viral infection and constant bacterial infections, that can trigger an autoimmune response. And then environmental factors or your occupational stress. And some people are just more susceptible, so they might have a genetic susceptibility. And then stress plays a role because we know stress can suppress the immune system, and when we suppress the immune system, our immune cells might not work as well. Okay, then we have treatments. Okay, so in treatments, really we're trying to suppress the immune system from attacking our own cells. So we can give corticosteroids. There's also tumor necrosis factor inhibitors, which basically cause cell death, and we want to try to inhibit that. And then we have immunomodulators that pretty much just modulate the immune system. There's also therapeutic plasmapheresis. This is where you're going to take components of the plasma, take out the parts of the plasma where, that we think is causing the disease, and then just return the rest of the blood back into the circulation. So it's kind of like when you do, a plasma donation. Your blood gets taken out of the body, and then it kind of processes it, and then you circulate it back in. All right, so then we have hypersensitivity. So in hypersensitivity, you have an excessive immune response. Or it could be the immune system is inappropriately triggered when it really shouldn't be. And as a result, what you're really seeing is you're seeing undesirable effects on the body. Usually doesn't occur on the first exposure. It will usually happen on subsequent exposures. There are different types of hypersensitivity. We have types 1, 2, and 3, which are mediated by antibodies produced by our B lymphocytes. And remember with allergy, we talked about IgEs being involved, so it's really mediated by those IgE antibodies. And then we also have hypersensitivity type 4. These are mediated by your T cells, so they don't require antibody production. So let's talk about our types 1, 2, and 3. So hypersensitivity types 1, 2, and 3 all involve your IgE. So the etiology, there's a strong genetic component and hereditary linkage in regards to our IgEs being involved. So what's the pathogenesis? This is also known as your immediate hypersensitivity, and it's called immediate because the reaction will occur within 15 to 30 minutes after exposure to your allergen. And so you'll see an allergic response, an anaphylactic type of response, and it really does involve your mast cells. And the mast cells, as well as basophils, are the principal effector cells that are involved in the response. And again, the IgEs play an important role here. So let's take a look at an example of this. So here we have our first exposure to an allergen. And this allergen will bind to our B cells. And our B cells will get stimulated and it will produce antibodies. So our B cells will turn into plasma cells and make antibodies. In this case, it's going to make IgEs against this allergen. Then what happens is these IgEs will bind to the Fc receptors on your mast cells. Now, when you get exposed to the allergen again, the allergen will bind to these antibodies that are now attached to your mast cells. And when they do, it causes your mast cells to degranulate. Essentially, that means it causes it to fall apart and release some chemicals. And these chemicals are a pro-inflammatory mediator. So they cause signs and symptoms of inflammation. The chemicals that are released include prostaglandins, interleukins, leukotrienes, and histamine. Now, histamine is bolded because it is the most important mediator. So it causes things like increased vascular permeability, vasodilation, and both of these will lead to hypotension, a drop in blood pressure, because when you vasodilate, blood pressure drops. When you increase vascular permeability, that means more components from the blood, including water, will leave the blood, dropping blood volume. You'll see signs like hives, and then you'll also see bronchoconstriction, which makes it difficult to breathe, increased mucus secretion, which also makes it difficult to breathe. So examples would be a reaction to certain drugs that you're allergic to, bee stings, asthma. So what will it look like? What are the clinical manifestations of type 1 hypersensitivity? So mild symptoms include things like the hives. We have seasonal allergic rhinitis, so inflammation of the mucous membrane in the nose causes things like stuffy nose, runny nose, sneezing. And then you can also see eczema. More problematic symptoms include localized edema. Remember, you're increasing permeability of your vasculature. You have throat constriction and wheezing, so the difficulty breathing, and then tachycardia. And anaphylaxis is the most life-threatening reaction. Occurs in a very small number of highly allergic individuals, but this is why you really need epinephrine injection right away. So how do we treat type 1 hypersensitivity? So antihistamines would be great because histamine was one of the most important chemicals that are released by those mast cells that causes all of these signs and symptoms. So an antihistamine would block the effects of histamine. Beta adrenergics would also work. So when you think of beta adrenergics, you should think of the sympathetic nervous system. So the sympathetic nervous system will, for example, decrease bronchoconstriction because the sympathetic is a bronchodilator. Corticosteroids, cortisol, what does it do? It suppresses the immune system to decrease the inflammatory response. Anticholinergics. So when you see cholinergic, you should think of the parasympathetic nervous system. Now here we have an anticholinergic, so we are going to block the parasympathetic nervous system. So the parasympathetic, for example, is a bronchoconstrictor. So by blocking the parasympathetic, we will no longer bronchoconstrict. IgE therapy, because this is all really initiated by the creation of those IgEs binding to the mast cells. And then epinephrine. So highly allergic people really should carry an EpiPen. It's given either sub-Q or IV, and it causes bronchodilation and vasoconstriction to make sure you can breathe and that your blood pressure doesn't fall too far and put you into shock. All right, so now what about type 2 hypersensitivity? This is also known as tissue-specific or cytotoxic or cytolytic hypersensitivity. And it occurs when antibodies attack antigens on the surface of specific cells or tissues, causing them to lyse and get destroyed. And it can be mediated by activating the complement fragments or also by phagocytic cells. Okay, so let me go over an example. And an example is a transfusion reaction. So here we have a person who has type A blood. So on the surface of their red blood cells, we have A antigens. If you are type A blood, you have anti-B antibodies in the plasma of your blood. Now, this type A blood individual receives a blood transfusion from someone who has type B blood. So when type B blood comes in, the type B blood has B antigens on its cell surface. So what's going to happen is your anti-B antibodies will bind to the B antigens on the red blood cell. And this immune complex will cause a reaction. So you will destroy your tissues, in this case, this cell, either by the complement, right, using membrane attack complexes. So again, these little water pores that get inserted, and the water pores cause water to come in, and it causes your cell to burst or lyse. Or you can cause macrophages to come and phagocytose and destroy you that way. Okay, but in any case, it's a tissue-specific attack of cells by antibodies. Okay. The next, so we also, another example of where you might see this is hemolytic disease of the newborn. So this is also known as erythroblastosis fetalis. It occurs during pregnancy in mothers who are Rh negative. So if you are an Rh negative mother, so Rh factor is another component of blood. If you have the Rh factor on your blood, you're Rh positive. If you don't have it, then you're Rh negative. So if a mom is Rh negative, she does not recognize Rh because she doesn't have it in her body. If her baby or fetus is Rh positive, and if the fetus's blood gets into the maternal blood, then that Rh that's on the fetus's blood is foreign to the mother. So the mother will start to make antibodies against the Rh factor. And those antibodies can cross the placenta and impact the fetus. Now, typically, it's not an issue in the first pregnancy. It's usually more of an issue in the second pregnancy. But what they will do to prevent this from happening is if the mother is Rh negative, they'll give RhoGAM, and that will really prevent the mother from making any Rh antibodies. All right, the last type of hypersensitivity that I want to discuss is type 3. This is also known as immune complex reaction. So here what happens is your immune system and phagocytic system really fail to effectively remove antigen-antibody immune complexes. So here we have an antigen-antibody immune complex. So the antibody bound to an antigen, you formed an immune complex. And it's circulated in your blood, and it wasn't removed from the body. Phagocytic cells didn't get rid of it. It's just circulating around. And as your blood circulates and maybe filters, it gets stuck in tissue. So it's really not tissue specific because the reaction will happen anywhere this gets deposited. And once it's deposited and it's stuck there, an immune reaction will occur in that part of the body. So here we have our cells coming and degranulating and causing negative impact on this area. Some examples of when we see this include glomerulonephritis, and this is something we're actually going to discuss again when we get to the renal lecture. But here, since we do a lot of filtration in the kidneys, in the glomerulus capillary, the Bowman's capsule, some of these immune complexes, as they get filtered, might get stuck in the capillary area. And so what happens? An immune reaction occurs in that area, causing damage to the capillary wall. Typically occurs 10 days to 2 weeks after a streptococcus or staphylococcus infection. Systemic lupus erythematosus is another example. All right, so now we're going to move on to deficient immune response. So in a deficient immune response, the immune response is like it says, deficient. It's not happening. There's no reaction occurring. So it could be due to issues with the lymphocytes or antibodies or phagocytes or complement proteins, but really there's a decrease in the immune response. Now we can discuss it in terms of a primary immunodeficiency disorder or a secondary disorder. So in a primary disorder, the issue is the immune system is just not working as well. Okay, so it's an issue with the immune system. So it may be congenital, it's present at birth, not necessarily linked to a gene. It could be genetic, in this case it is linked to genes, or it could be acquired. An example would be HIV/AIDS. Now, what are the signs and symptoms of a immune deficiency issue? Well, the signs and symptoms would be you get sick a lot. You get a lot of infections. So you have and the infections are severe, they're unusual, they're unmanageable because your immune system is not responding. In secondary immunodeficiency disorder, again, signs and symptoms similar. You get sick a lot. The infections are, worse than they really should be. But the secondary immunodeficiency disorder is occurring not because there's necessarily an issue with the immune system, there's an issue with something else. For example, maybe you have issues with hormones, too much or too little. For example, excessive corticosteroids can increase susceptibility to infection. So having too much corticosteroids and cortisol might or will suppress the immune system, and as a result, you might get sick much more often. Also, we have defective hormones. So low corticosteroids can also increase cause immune deficiency, because in this case, it makes you more susceptible to autoimmunity. Okay, lastly, other contributing factors to immunodeficiency disorders include poor nutrition, stress, drugs, and cancer treatment. So these are all things that can suppress the immune system. But notice in all of these, the immune system itself is not the issue. There's something else. You have bad nutrition, and that's why you're not making your immune system. Or you're getting treated for cancer, and your bone marrow is being suppressed, and that's why you're not making your white blood cells. So it is a secondary disorder. All right, so we're going to end with a quick quiz. First question. The CDC recommends that HIV antibody testing takes place when? Immediately after exposure, 1 month, 3 months, or 35 months? Well, immediately after exposure is too soon. So is about 1 month. The best answer is 3 months after exposure. So that gives your body time to respond and make antibodies, and enough so that you can actually test and detect it. 35 months is just waiting too long. Now, which immunoglobulin is responsible for hypersensitivity? Remember hypersensitivity, think of allergy, so we should automatically think of IgE. Okay, thank you.